procedures, and that's going to cover a wide range of exams, and there is going to be a bit of overlap of chapters with this particular subject we're talking about. The reason we're doing all these different chapters here is because they're very small sections you have to go over. So literally we can get a whole chapter done in a day for each of these areas, some less than a day. So as usual, I'm just going to be simplifying this down to just the stuff you need to know for your registry purpose, even though we could probably greatly elaborate on some of these areas. But probably the one we're going to spend the most time on would be reproductive and myelogram. Arthrogram, biliary, and orthoreconography are going to be very brief. So arthrograms you guys should be very familiar with because most of you going through fluoro have done at least one arthrogram. Y'all know what I'm talking about?
That's fluoro? My gosh, Melanie, it's fluoro.
I remember the story, yes. Indeed it is. Indeed it is. And it's a fluoro of what, Charo?
I think the joints, I believe.
You think or you know?
I think, because I don't even know if it's fluoro, but I'm gonna go with the joints. I take joints for aid.
Okay then. Okay then. So obviously guys, the word arthro refers to joint exams. Biliary duct, we talked a little bit about biliary already when we learned how to label the biliary tree, the liver, the gallbladder. We're going to revisit that a little bit this unit because we'll be actually talking about the actual procedures that we do for biliary exams. Can y'all name any biliary procedures that you may or may not have seen before? Does anybody know? They don't do much at Hair South, but I'm curious if y'all have seen or done one by any chance. There's one big one. Not, well, that's bladder. You heard of cholangiogram? A cholangiogram would be a fluoroscopy of the gallbladder, and it's another big one that they often do on kids. You probably have not seen it at Hair South, but they do them almost daily at TCH. It's called an ERCP. ERCP is where they're going to use a camera to go down into that biliary tract, as well as be using fluoro to image the gallbladder and that biliary tree. And then, of course, we have reproductive exams. Has anybody done any reproductive procedures out there?
HSG.
HSG,
Yes, what's that stand for?
Solenography.
Lord have mercy, no.
Mr. Donahue, hysterosolenography.
A what? Sterile solenography.
Hysterosolenography.
Oh, no, no.
It's on
Close.
HSG.
Hysterosalpingograms is what we're talking about. Hysterosalpingograms.
I knew I was close to that.
So those are still done quite often.
But they're so
We're going to talk about those.
Is this a chapter?
It's chapter
Multiple
13.
chapters.
This one starts off, this one, right?
We're starting with 13, yes.
Yeah, that's the arthrography.
Yeah.
So when we talk about hysterosalpingograms, and as far as the male side goes, because hysterosalpingogram are female only, on the male side we'll talk a little bit about some of the sonography exams they do for males, because when it comes to male reproductive, that's delegated only to ultrasound. So they're the ones that will be doing those scrotal exams you always hear them talking about across the hall there. So we don't have to worry about that. That's a sonography-based area.
Do they use contrast on these two?
On the hysterosalpingogram, yes.
But on the male?
Not for the sonograms, no. Now, myelograms, some of you have done this as well, because some of y'all brought those comps to me. What's a myelogram?
Oh, it's when they go into
You know, the spinal taps y'all been bringing me with the needle? Absolutely. So a myelogram is going to take it a step further. A lot of you have just done the spinal tap where they take the fluid out and just do a couple of fluoroid exams. But the myelograms would be actually fill up the whole subarachnoid space with contrast surrounding that spinal cord and do a full look at the entirety of that spinal cord. So we'll talk about those. And finally, we'll wrap it up with orthoreconography. Ooh, that's a mouthful. Orthoreconography. Anybody know what that is? It is bones.
His name is Stefan. His name is
Yeah, Mr. Rington's name is in there, but it actually has nothing to do with him. I don't know why they put this name in there, but it's actually a fancy way of saying a long bone study. Mostly for the legs. So if you have a kid that comes in with uneven legs, which happens more often than you might think, they're going to do a long bone study and stitch those images together, much like they do for Scoliosis exams, when they stitch the images together to get an evaluation and measurement of those long bones to see how they can fix the height of that patient, give them some quality of life back so they can walk normally. Have you ever seen someone with uneven legs before?
Do they usually have like a brace?
They often do, and usually they will until they go in there and like file one leg down, or give it an extension. They can do multiple things. They can either file it down or give it an extension.
Because they're kids.
When they're kids. When it's an adult, much more difficult. Yes. So we're going to start with contrast arthrograms. And here we go, guys. So what is it? What we just described is going to be a contrast examination of the soft tissue structures of joints after we inject contrast media. So based on what y'all seen in clinic, what are some of the more common arthrogram sites y'all have witnessed? Shoulder, that's a big one. Knees. Ankles. Hip.
Wrist.
Oh, yeah,
Wrists. All the major
Yeah.
joints. Elbow. Really, every joint in the body can be done under arthrography depending on how many issues they're having. So what kind of issues might a patient be having specifically that would call for an arthrogram? Extreme arthritis. Extreme arthritis. So what they will do is they'll fill these joints up with contrast. And what do y'all think they're evaluating with that contrast specifically in those joints?
Blockage.
Yeah, they're looking for
filling up
blockage,
the,
but what are we lining up specifically with that contrast?
The space.
What's that space called?
Yeah.
It's called joint space, but what else is it called? It's the main type of joints we've talked about in previous. Synovial, very good. The synovial joint spaces. So arthrograms. Hey, it gets me excited. I'm glad. Arthrograms are going to specifically line up synovial joint capsules because they want to see if they can restore some of that lost joint capsule. Because what's arthritis? What is this joint pain coming from? The fact that that joint space, that joint capsule, that synovial membrane is breaking down, causing those bones to actually erode and rub up against each other. Which, as you can imagine, if you got two bones rubbing up against each other, that's going to cause a lot of uncomfortability, a lot of pain. What now?
The cartilage is deteriorating.
It's all deteriorating, yes. Yes. So what do y'all think this is right here? I hope y'all know what that is right now.
That is a wrist. The flip is a wrist.
Is that a wrist or is that a foot? Y'all sure that's a wrist?
Yeah, that's a scaphoid.
Thank you for saying that. Yes, it is. Scaphoid right where? Right here?
This
Is that your
opposite.
scaphoid?
Opposite. That's
Okay, just making sure. Just making sure.
You should have got Dr. Black in here for that one.
Yeah.
I think not. Anyway, the types of contrast we'll primarily use in arthrograms, guys, are going to be radiopaque and radiolucent. Both can be used. Depends on what the doctor wants to see or not see on what they're going to choose with that. So obviously, you guys should be pros at these by now because every single one of you in here have done an arthrogram by now. At least I think you all. You haven't? Really? All right, most of you have had an arthrogram at least once so far because they do them a lot at Harris Health.
Oh, yeah, that's for sure.
Yeah, they've done them, but like every time I have a rotation.
A lot of,
They don't
what
do
is
it.
it, quarter, whatever shots.
Okay, so even though they're very popular, we're seeing them actually start to go away in most hospitals. Not at Harris Health, because Harris Health being a government facility, they're going to usually use, I don't want to say the cheaper route, but it's the more affordable route.
The county's route.
Is that
Cheaper.
Okay, I'll just say it's the cheaper route.
Economically
Now, why is
friendly.
arthrogram starting to go away? Because actually CT has completely taken it over, almost totally. It's much better imaging, much faster, much more detailed. MRI as well. I mean, MRI is excellent at looking at joints. If you've ever seen MRI images, it's just superior to X-ray in every way. And of course, ultrasound as well. It's going to be considered a more superior medium to X-ray on doing arthrograms. But like I said, being that it is a cheaper option, that is still being utilized a lot at Harris Health. Whereas other facilities that aren't government funded, we're seeing these pretty much disappear. And they're just going completely to CT, MRI, and ultrasound. Really great question to make note of there, by the way. That's the only hint y'all get in this chapter. Don't expect any more.
Oh, all I heard was Harris Hill. What was it?
I'm only saying it once.
Oh, Harris Hill.
There's a decrease.
Who were we? So I said that it's going away. So arthrograms are starting to become obsolete because of these three
Oh, gotcha.
modalities.
So CT, MRI, and ultrasound.
Yes, they're considered superior for imaging the joints.
So would they do the orthography with CT?
Then it will be true for the knee joint
Or
as well.
expensive?
It will be true for the knee joint as well. Or the
Yes.
knees as
Oh
well.
yeah, all
You do
joints.
so many knees in that.
Yes. In fact, Ms. Bonilla could probably tell you more than me because she works CT. Did y'all do a lot of arthrograms in CT? Y'all did not? Okay, well, there we go.
Not at MD Anderson.
Not at MD Anderson.
Oh, y'all look at that hair, it's definitely gonna
Okay, so ACR, you know what the ACR is? You should know what the ACR is.
The American College of Radiology.
That's up there if you forgot the initials, yes. American College of Radiology, they rank contrast arthrography very low to not all as an appropriate diagnostic tool. So they actually rate it as very obsolete overall. Why? Once again, those other modalities are just considered superior. So what would be exceptions to still doing an arthrogram? Choosing it over CT, MRI, and ultrasound?
Cost.
Cost, yes, excuse me, hiccups. It's that meal y'all got me, he's got me got hiccups. That meal is fantastic, by the way. Contraindications for gadolinium. Y'all know what gadolinium is used for? What?
People have,
What do we use gadolinium for?
Control.
What modality?
CT.
MRI.
Oh, MRI.
MRI.
Oh, yeah.
MRI. Yes, so if they have an allergy to gadolinium, we won't use that medium, we'll use a regular arthrogram. Aspiration and suspected septic or inflammatory arthropathies of the shoulder, whatever that word is. And following knee arthroplasty as a routine follow-up, that's another reason we do an arthrogram over those other modalities. And finally, to rule out the hip as referred pain source after other negative imaging. So that's the 4 reasons that we would choose regular arthrograms over using the typical CT, MRI, and ultrasound modalities.
What does that mean, to rule out the hip?
To rule out the hip as referred pain source. I think what that's saying is, I don't know what that's saying. Let's see, I gotta think about it for a second.
Because you never rule out something as a doctor, and insurance wouldn't pay for it.
That's what you're saying.
I don't know, that one's not clicking with me.
That's what you're saying.
I'm gonna have to look at that and let you know.
What's arthro?
Arthroplasty?
To
Where's
make
that
it
at?
jump.
I think it's saying, like after the other modalities have
Following knee arthroplasty.
ruled out the hip.
That's when
as a
they
source of
pull the
pain,
fluid out.
and it was negative results, arthrogram would be the last option to rule out the hip as a source of pain.
That makes sense. That makes sense. They drugged me with that meal. My brain's not firing all 4 cylinders right now. It sure was good though. Okay, so contrast arthrograms most likely performed for specific joints. You guys named all these just recently earlier. Being the shoulder being the most common. Please put a star by that and remember that. Shoulder is the most common. But knee, hip, and others like the wrists, elbow, ankle, anywhere you have those big joints can all be candidates for arthrograms, depending on what kind of pain they're having and what kind of issue that patient is having. So thus, any joint can actually be evaluated if needed. It can even be your finger joints, your DIP or PIP, if they wanted to.
Any joint?
Any joints. That's your main ones that we're going to look at right there. So what joint is that red dot referring to? I'm going to go back to Rad Pro 2. Not the glenoid cavity, that's a landmark.
Scapulohumeral.
Thank you. Scapulohumeral joints. Scapulohumeral joints. And what kind of joint is that?
It's a synovial.
It's synovial, but what's the movement type? Ball and socket, also called what? What's the alternative name for ball and socket? What'd you say? Close. What's the shape of it?
Sphenoidal?
Spheroidal. Spheroidal. What kind of shoulder is this?
Left.
No. No. What kind of shoulder is this? First off, it's the right shoulder.
External.
External.
I'm hearing both.
External.
What is it?
External, it's a
You don't
right.
need to know that because they're going to give you an image just like that on your registry. You got to identify which type of shoulder external it is.
External.
I'm hearing both answers.
Axiolateral.
I believe it's
It's
external.
external.
I believe Ms. Bonilla is correct.
It's
It's an external. But why is it external? Why do we know it's external? Because you need
The
to know.
bump is on the lateral side.
What's in profile?
Oh, yes.
Greater tubercle profile. Please don't forget that. I know that was a long time ago. It was a year ago. Please don't forget that.
My little tip is I see like 2 mountain peaks on that.
Yeah, that's what I.
Two little peaks.
Oh, okay.
That's good. That's
And Miss
good.
Bonilla is coming 2 for 2.
She knew I was struggling today, so her spider sense. I appreciate it. Okay, so look at the soft tissue structures of joints. See, I can't even talk anymore.
Look at y'all being here.
Just send them home.
They gave me a
Yes, take us home.
they gave me a very heavy meal. It was really good though.
That's what we're calling it these days?
Very heavy meal. Yes. All right. So radiologic examination of soft tissue structures of joints. After injection of 1 or 2 contrast agents, they're going to be termed pneumoarthrography. What's that mean? Pneumoarthrography?
Air.
Air. So air and what? Air and contrast. Air and contrast. Opaque arthrography and double contrast arthrography. So those are 3 different types of mediums we can use for arthrograms. So what would be the most common? That last one right there. Why is double contrast always the most superior type of contrast fluoro that we do? Whether we're talking about GI, joints, whatever. Why is double contrast always the best?
It covers all the density.
Better visualization.
You know, all that jibber jabber, I think I heard the right answer. That was I think all 3 of you said something correct there. So one at a time. What'd you say first, Shaheen?
Because it covers all the densities.
All the densities. What'd you say, Jay?
Better visualization.
Better visualization. I think you said
It allows you to see the different structures better.
correct. It kind of gives you a more internal view of that structure. Whereas if you have one single contrast density, it's all just going to look like one shape. But if you have the double contrast, you can see the varying densities. You can see inside, more internal to that structure, and get a better overall visualization of what you're seeing. But right now, when you look at that, it kind of just looks like a mess, right? Y'all seen these at Ben Taub and LBJ? They often look just like this. A bit of a mess. Yes, no?
I don't know, I can't tell you.
Yes, sir.
All right. Goodness. All right, so when they do these injections, they are going to use a local anesthetic because it can be quite painful. If you ever had a needle in your joint, I'm sure you'd want to have an anesthetic, help deaden that for you. Yeah, you probably have not had that done, but believe me, you'd want that deadened. Now, if there is joint effusion, by the way, what is joint effusion? That's a very
Fluid
common
in the
pathology for these
Fluid.
procedures. Fluid in the joints, unwanted fluid in the joints, because synovial fluid is desirable, but if we have extra fluid in there, we're going to aspirate it. So what's aspiration mean?
Take it out.
Take it out, take it out. So they'll do that after local anesthesia and prior to the contrast administration, because, well, you tell me, why would we want to remove the extra fluid before contrast?
So it doesn't dilute, so.
It doesn't dilute, we don't want to mix, and we're not gonna really see the joint very well, we're gonna overload it with fluid. So we need to aspirate the extra fluid so we get a good visual density of what we're looking at. So the contrast, of course, will be administered under fluoro, so we can see what we're doing. After it's injected, the radiologist will manipulate the joint to distribute contrast. Now, you should be seeing the doctors do this. What are they doing to manipulate the joint? And why? Have y'all seen them manipulate the joint after they inject contrast? Like moving the arm around, moving the leg. They're not moving the joint around? They're just leaving it there?
Yeah, not really.
Well, they're just doing it wrong, aren't they? Well, they should be manipulating the joint, and why do you think that's important?
So it can cover all the space.
To coat the entire joint space, absolutely. Because if it just sits in one area, it's just going to sit in that one area. We're going to move that joint around to coat the entire synovial capsule. Yes. At that point, there'll be radiographs taken if needed, or spot films most likely, because that's mostly what your doctors do these days. They just take spot films themselves with that fluoro tower. But they may ask you for like an external internal shoulder or a Grashy shoulder, something like that. Great question. If a doctor was ordering plain films on a shoulder arthrogram, and they ordered you an external internal view shoulder, but they also threw a Grashy in there, why do you think they would have thrown the Grashy in there? Grashy, Grashy, potato. Why would they order the Grashy for an arthrogram?
Open up the joint.
What'd you say?
They open up the joint. space.
So
Scapula.
elaborate.
Cause like when you kind of oblique them a little bit, that's when the contrast is gonna go into that space.
No, 'cause the brachiae is.
Not exactly, but you were on the right
brachiae
track.
Is used for the scapulohumeral joint space.
So so the gracie is specifically done to open up that joint, which is why they would ask for that film to get the best view of that synovial joint filled with the contrast. That's a really good point to write down. It's not in your notes, but I would write that down. The gracie is done specifically for the joint space, so that would be a very likely spot film they would order you for a shoulder arthrogram. So a lot of those positions we learned back in Rad Pro 2 that specifically open up those joints would go hand in hand with some of these arthrograms to get the best visual. Because when we do obliques, y'all remember what's the main reason we do obliques?
To open up joint
To
space.
open up joint spaces. Correct. All right, so still looking at shoulders here, guys. We're just going to break this down. We're going to go over some of the positions. So what's the main reason we're going to perform a shoulder arthrogram? Well, I'm sure y'all heard of a torn rotator cuff. Very painful injury. I've never had it myself, but I've had friends that have had that. It's very painful from what they tell me. So if they have a torn rotator cuff or a glenoid labrum, that's two of the main reasons they'll do this. Not the only reason, but two of the big reasons. Persistent pain or weakness, or a frozen shoulder. Frozen shoulder can come as a result of severe arthritis. You just literally can't manipulate your shoulder. It's like it's frozen in place, very stiff. So for shoulder arthrograms, we can use single or double contrast. Most commonly, double contrast would be the superior method. Now you're going to see these numbers. I know y'all love numbers. You can all collectively groan. You do need to know these contrast amount numbers here, guys. So for a shoulder arthrogram, single uses 0 to 12 mLs of positive agent. That's for single contrast. If we're doing double, we're going to do 2 to 4 mLs of positive and 10 to 12 of air. So quite a big difference between the two there. So one more time, single contrast, it's just contrast by itself, 0 to 12. If we're doing air and contrast, which would be double, 2 to 4 contrast, 10 to 12 air. Know the difference between those two. Now, most common injection site, very similar to our positioning for a shoulder. 1/2 inch inferior and slightly lateral to the coracoid process is where we'll inject. That will go directly into that joint cavity. We'll fill up that synovial capsule.
I have a question. So, like on the test for the double, like in the book it say 3 to 4. So would you say something like 2 to 4, and we could select like
3 to 4 would fit within that
okay,
range, so
I just
yes.
want to make sure. Okay.
Yes. Good question. So, speaking of test, what's an image you can expect to be on this next image review?
The shoulder.
Shoulder. So review your shoulder anatomy. My juniors, because we just did the shoulder lab, they call it the trashy grashy.
That's what I'm saying, trashy, grashy, grassy.
I'll say, well, trashy's so negative. Let's just call it the flashy grashy.
Oh, that's kind of creepy.
Flashy?
I don't like that.
I didn't say flash, I said flashy.
What'd you say?
I didn't say flash, I said flashy.
Flashy.
Okay, let's rewind.
Nobody's flashing anyone.
Please.
Please don't. Okay, so we looked at this image way back a year ago in Rad Pro 2. I told you don't worry about this yet. I said we would revisit it in Rad Pro 4. So here we are revisiting this kind of nasty image where we got to look at some ligaments and some joints. So these are some of the few actual joint anatomical landmarks that we make sure we know, specifically for our arthrogram procedures. So I'm going to tell you which ones to focus on. Of course, all the bony anatomy, which you should already know. We're going to add some new ones. That being, big one being the articular capsule. That's your synovial capsule. It's that blue area you see right here. Your subdeltoid bursa. Your biceps brachii tendon. And your synovial sheath. Adding to that, we have the deltoid and the bicep. Y'all should know what those are if you exercise. And if you don't exercise, you should know what those are. And the supraspinatus muscle up here in the shoulder as well. It's going to be a superior muscle. And subacromial bursa, that's another new one. So let me say that again, guys. Subacromial bursa, subdeltoid bursa, articular capsule, biceps brachii tendon, synovial sheath, deltoid biceps. All those are some new pieces of anatomy to make sure you memorize for your upcoming test. We don't study a lot of ligaments and muscles, but this is one of the few cases we do.
When I was in college, we labeled cat, so I know where all these muscles are on a cat,
Good.
but not a human.
Not good. Sounded good. Oh, one more, guys. Glenoid labrum. It's another area we're going to evaluate with contrast. Glenoid labrum.
Is it like in the armpit?
Basically, yeah, the axilla.
So that's,
The burst.
that is, the part that can be torn also.
Yes. Yes, it can.
So is that all of them that are
Hmm?
Did you miss any of them?
Did I miss any words?
No,
I didn't say the ones you should already know, like glenoid fossa, clav.
So basically, do we have to know all of them, or did you?
The ones I just know this whole chart. Yeah, know this whole picture. Yes.
No, you just said the.
So this is one of the few images where we have to actually memorize muscles and tendons. There's not a lot in X-ray, but this is one of the few we have to actually know. It's all related to your arthrograms. This is much less info than the last two.
Less info, but more wordy.
We're still on shoulder. This is like one of the first sections. Exactly.
The shoulder's the most wordy one because that's the most commonly done. Cool your jets. You haven't seen the rest yet. All right, so what projections will you most commonly do if they were to order plain films? Well, your AP internal, external, just like a routine. Your AP oblique 30 degree. What's the actual method name for this? That's the Grashy or Gracie, however you want to pronounce it.
Would that just be like a scalp?
That's not the scalp wide, it's different. So Grashy, Gracie is an LPO, RPO specifically, and it's a 30-degree specific oblique. Axillary and tangential, so that's gonna be like your Lawrence methods. Remember the Lawrence methods? Okay. Vaguely remember your Lawrence methods?
I don't know.
Remember this X-ray right here, guys? Going through the armpit?
Yeah, that's the Lawrence method.
That's the Lawrence method. Now, even if we go ahead and do this regular arthrogram, often CT is going to be used in conjunction to get even better visualization. So they're going to fry that patient extra crispy after that arthrogram. Tangential is like the reverse Lawrence. So with a regular Lawrence, infero-superior axial, we're going through the armpit. The tangential would be going from the posterior side, like top to bottom.
Yeah, they shoot from the top.
Is that the one where they make you like reach over?
Yeah.
Yeah, they have to
Yeah.
reach over and then they just.
Yeah. You can check for dislocation doing that.
How would you check it?
Turn your head.
Well, look, if you looked at an image like this,
She said,
you'd be able to see if it's.
Yeah, but when it like I had a kid the other day and
Yes,
he
I'll get
had,
to you.
he had a broken clavicle and they wanted this one but he couldn't do it. So I did a
By the way, that's your tangential there. This is the tangential at the top. This is Lawrence down here. This is infero-superior axial. This is tangential. All right, 2 more images there, guys. Now don't worry about these cross-sectionals. I don't expect you to know cross-sectional imaging yet. Come back to CT and MRI next year if you're interested in this. That's what your cross-sectional imaging would look like compared to your regular X-ray over here.
She says, like, I'll tell you where you want.
Now, let me ask y'all this. What type of shoulder X-ray is this?
That's an intern.
Neutral.
How do you know it's
No.
You
internal?
don't see the greater.
It's neutral.
Neutral. It's not neutral. So I'm hearing mostly internal. How do you know for sure it's internal? What's the main landmark you look for?
Where's the lesser tubercle?
Right here.
Oh.
Here's a lesser tubercle right here. And it covers up that glenoid fossa as well. Why are we packing our stuff up so quickly? I'm not done talking. here.
So that whenever you are done talking, we can go. They can just
I
zoom.
won't give all the real test questions now. Just type your stuff up.
Go ahead.
Okay, so also, as we already talked about, increasingly this is being performed at MRI. Big difference is they would inject gadolinium for
Yes.
MRIs. Please make sure you know that. The specific contrast you're going to inject for MRI is gadolinium.
Remember that, y'all. Gadolinium.
So y'all miss that on the next test.
We won't, I promise. Yeah, gango.
Looking at that MRI image, how is the arm rotated?
External.
Neutral.
You know,
Or
it was
internal
laying
and external.
That's good.
Is that not the greater on the left side?
That looks neutral.
Neutral.
This is
Yeah,
external.
It's external.
This is external. There's the greater
Right.
tubercle. Now let me ask y'all this, because you need to know this. Let's test how much we know since we're trying to get out of here so quickly. If I have the shoulder in external rotation, how are my epicondyles related to my IR?
Parallel.
Very good. If I had an internal rotation, how would be the epicondyles be lined up to the IR?
Perpendicular.
Okay, y'all restored my faith a little bit.